Emicizumab is a monoclonal, humanized, recombinant, bispecific antibody that is able to substitute for factor VIII. So essentially what emicizumab does is that it connects activated factor IX with factor X and thereby allows the clotting process to proceed like factor VIII was present in the system. So factor VIII works as a cofactor, and emicizumab compensates for this a cofactor activity. It is important to remember that emicizumab can only substitute for factor VIII and not any of the other clotting proteins. So it can only be used for for hemophilia A and not for hemophilia B. Factor VIII and emicizumab are different proteins, and the differences are as follows. So factor VIII needs to be activated, whereas emicizumab does not. Factor VIII has multiple sites of binding on the clotting protein cascade, whereas emicizumab has only one site of binding. Factor VIII binds to 1 Willebrand factor, whereas emicizumab does not. Factor VIII also binds to phospholipid surfaces as well as the activated platelet, whereas emicizumab does not. Factor VIII activation in physiologically results in 10 times increased generation of thrombin, whereas emicizumab is not as effective. Emicizumab can bind to both activated and non-activated factor IX and 10, whereas factor VIII can only bind to activated IX. So my personal experience with emicizumab is that we participated in the studies. The studies were open at our center, and our patients were part of these studies, and so we have had the opportunity to witness what the efficacy and safety was for this product in our patients. The advantage of emicizumab is the fact that it can be administered subcutaneously and that its half-life is extremely long. And both of these are a significant advantage in the pediatric group because the frequency of administration makes it very difficult, especially intravenously, for our patient population. And subcutaneous administration makes this significantly better in that the patients and parents do not have to be taught how to access a vein. And subcutaneous administration once weekly or once monthly is a significant improvement over every 2 or 3 days that we were doing previously for our patients. So emicizumab offers these two primary advantages to our patient population. Emicizumab today has been approved for the use in all patients with hemophilia A, both with and without inhibitors, and of any severity, which means that all patients with hemophilia A would be eligible patients for this product. In addition to the decreased frequency of administration and also the subcutaneous administration, it's also important to make sure that the product is efficacious. And in the studies with emicizumab, we have been able to demonstrate that it was extremely efficacious for both inhibitor as well as non-inhibitor patients, in that the bleeding frequency was decreased dramatically in both populations of patients. I think emicizumab will truly change the treatment paradigm for patients with hemophilia A, in that we would be able to use this for prophylactically for prevention of bleeding. The one important thing, though, that we have to remember is that it doesn't normalize the coagulation in these patients, and therefore we are still unsure as to exactly how we can utilize this in certain populations of patients, especially those who are very active or who play competitive sports. But for the normal run-of-the-mill patient who is non-compliant, who potentially does not want to treat very frequently, who is not extremely active, this would be an ideal prophylactic method of treatment. We would be able to use it on a weekly basis, and in many patients, maybe monthly basis. For the adults who are not excessively active, this would be a marvelous, remarkable treatment option, in that they would be able to administer it weekly or monthly and still not experience any significant bleeding. In spite of what I'm saying at this point of time, we have to remember that breakthrough bleeding can occur in these patients, so there will be a need for regular product to be used for treatment of breakthrough bleeds in these patients. So I anticipate that most patients would go on prophylaxis with emicizumab, and breakthrough bleeds would then be treated with recombinant or plasma-derived factor concentrates. The number of doses that might be required for treatment of breakthrough bleeds may be significantly decreased, in that most patients would be sort of converted into a milder phenotype. Even if you have severe hemophilia, you are potentially going to be treated by somebody who has mild hemophilia A. And therefore, which means very small bleeds or very minor bleeds may not actually even require treatment. Only major or significant trauma will need to be treated. It is important to remember that patients should be able to recognize and identify what is a major and not major bleed. And so education will still be needed for these patients in order to ensure that they can identify bleeds that require treatment immediately, whereas also identify bleeds that are minor and potentially they could wait and see if treatment is required or not. Venous access, practice with venous access is the other factor that I think about. If patients go on subcutaneous treatment and are getting treated once or twice a week or month, then will they forget how to access their veins? If they don't have as many bleeding complications moving on, will they need to come to the emergency room or hospital for every bleed because they no longer know how to access their veins and receive treatment at home? Will this potentially result in a delay in treatment is the other thing we need to think about. But I anticipate and hope that patients will still maintain their venous access proficiency and will be able to treat at home appropriately if needed. These are things that we'll learn as we move forward. Cost is a concern, but at this point of time, we anticipate that because the frequency of bleeding is going to be significantly decreased, that the cost would potentially be absorbed into that. Compared to 2 or 3 times weekly treatment with regular factor products, if I'm treating once a week or once a month, potentially the cost would be equated there.